All right, so neurogenic claudication, we'll touch on a lot of different realms of it. We'll touch on the anatomy just to start off with, go through some clinical presentation just as an overview, and then we'll kind of dig into some of the data to see what's out there. So in overview, lumbar stenosis is considered a degenerative condition that's characterized by narrowing of the lumbar spinal canal. The causes are multifactorial, can be caused by multiple etiologies over there that are typically causing anatomic compression of some sort. It could be facet osteophytes, it could be spondylolisthesis, any combination of the ligamentum buckling, hypertrophy, and synovial cysts. I think it's also important to touch on the prevalence just to shed light on the fact that this is a very common disease process. It's one of the most common reasons for spine surgery in the elderly patients. In terms of surgery for lumbar stenosis, there are over 500,000 laminectomy procedures that are performed. So obviously in terms of relevance, it's very, very near to us. So neurogenic claudication typically occurs from stenosis that occurs in the central aspect of the canal. Again, alluding to that first slide, could be for a combination of the multiple anatomic features that are there. And pathophysiologically, what happens when you have this central canal stenosis, you have a decrease of the blood flow to the nerves. So as these patients are exerting energy for longer periods of time, there's an increased oxygen demand, which exceeds the blood flow and causes these symptoms. And in comparison to lateral recess stenosis, which we'll also define anatomically, central stenosis usually happens in bilateral lower extremities, causing neurogenic claudication. And these patients typically complain of pain, numbness, tingling, weakness in their back and their lower extremities, usually bilaterally, that is exacerbated by walking, standing, upright exercises, any sort of prolonged walking. And you can see the typical shopping cart sign that we learn about. And these patients get relief with sitting down and forward flexion. And what this effectively does is it decompresses the spinal canal by increasing the interlaminar space. It can cause some increased tension on the ligamentum, so get rid of some of the buckling and open up the area in which the nervous structures are running through. Also important to take note is that these patients usually have a normal neurologic exam, which can be different than having a single herniated disc or any sort of lateral recess stenosis that's pressing on a specific nerve. So the anatomy of lateral recess, it's bordered laterally by the medial wall of the pedicle, posteriorly by the superior articular process, the ligamentum flavum, and medially by the lateral aspect of the dura. And most commonly, if there's any sort of facet arthropathy that is causing overgrowth or an osteophyte formation from the supromedial aspect of the superior articular process, you can see in the image how this can cause some irritation or compression of the nerve. And especially as it grows, it can grow more anteriorly into the vertebral body and decreasing the foraminal area. So the gamut of treatment options is the standard conservative, and then you get into operative options, and we'll touch on those as well. I wanted to bring this up. This is just an overview of the SPORT trial. And what they did, this is a little different because it was forced spondylolisthesis, but they had the patients that were randomized to fusion versus no surgery. Of course, there are a lot of drawbacks to it and criticisms of it, but the high crossover rate being one of them. Overall, though, there was significant improvement in a lot of the SF-36 scores. And what they found ultimately was that at 2 years compared to non-operative care, surgical care was better. So laminectomy is not perfect. Laminectomy, and when I say laminectomy, I mean it in the traditional sense of removing the spinous process, the interspinous ligament, the supraspinous ligament, and a substantial amount of the bony aspects of the lamina. But when you do this, it does not typically stop the progression of the disease. The disc can continue to collapse. You can continue to have degenerative changes in comparison to fusion procedures, which would, at that one segment at least, stop the progression of the disease. The disc can protrude into the lateral recess and neural foramina, again, more alluding to the progression of the disease that can occur. Laminectomy also is not fraught without complications. So there's a lot of papers out there looking at complications of treatments with spinal stenosis, epidural hematomas, dural tears, revision surgery, epidural scarring, and for multiple reasons that can make things a little bit more complicated for the patient as well as the surgeon. So I think we're on a search for less invasive alternatives. When you talk about non-operative care, I think it's kind of the standard gamut of injections, whether it's selective nerve root blocks, epidural steroid injections, some of the pain management modalities that can be implemented through them. Physical therapy, as we mentioned before, the extension of the spine causes a decrease in the space through which the nerves are running and does the opposite of decompresses the canal, which causes symptoms. So a lot of flexion-based exercises are oftentimes what are recommended, anti-inflammatories, lifestyle modifications. And then when you go to surgical decompression, I think it's important to note that there's different techniques that we can implement in which to take care of these patients. So traditional laminectomy, again, the traditional sense of taking off everything, the supraspinous ligament, the majority of the lamina. One of the pros is that there's good discernibility. You're removing a lot of the lamina. There's a fair amount of space that is available. You can work with. In contrast, though, something to take into consideration is that you're resecting a lot of the stability. And are you, by removing some of these osteoligamentous structures, the posterior ligament is complex to some extent, are you creating some sort of iatrogenic instability? Additionally, by removing and stripping off the muscles, are you causing extensor muscle weakness? And if so, then to what caliber is that going to relate to the patient's pain postoperatively, to the recovery postoperatively? And is there any sort of resemblance to failed back syndrome that is there in the literature? So that brings us to laminotomy and laminoforaminotomy. And the main thing about this part of the procedure is that, or rather a completely different procedure, is that you're keeping the posterior ligamentous structures intact. Therefore, you're maintaining a sense of stability of the posterior aspect of the spine, which is a significant part. You're maintaining the tension band. And on a downside to this, though, you're working in a smaller operational space. So it's a little more technically challenging in that it may take getting used to by preserving some of it. To do this from a unilateral approach and a bilateral decompression, I think is really where the learning curve may start for a handful of cases. On the positive, though, you want to consider that, are you reducing postoperative pain compared to stripping off the muscles and removing a significant part of the bone? And are you truly maintaining posterior stability, which will reduce adjacent segment degeneration or degeneration of that segment in itself? So there are several studies out there that are looking at just this. There's functional outcomes looking at laminectomy and laminotomy. This is a single center prospective study, and they stratified the patients looking at laminectomy or laminotomy procedures. They looked at ODI and VAS scores preoperatively and up to 1 year. And they found that both surgeries were equally effective in improving leg pain and back pain. They didn't consider alignment, which I think is something that we look at more so now than we did previously, but it's something to consider. There's also a 1 year follow-up. So if you're considering adjacent segment degeneration or further degeneration of that segment, I think 1 year follow-up may be a little early for that. This was an interesting study that looked at the outcomes by randomizing the laminectomy/laminotomy. And what they did, prospectively randomized study, 120 consecutive patients, and they looked at the VAS scores, ODI, patient satisfaction up to 1 year, but they stratified the patients into 3 different groups. One of them was a bilateral laminotomy group, maintaining the midline structures, a complete traditional laminectomy group, and a trumpet laminectomy group. So the bilateral laminotomy, as I mentioned, they are maintaining a significant part of the spinous process. They're taking off a caudal portion of the cephalad lamina, cephalad portion of the inferior lamina, and doing their decompression. All in all, what they're doing is they're maintaining the supra-interspinous ligaments and a considerable percentage of the lamina. The trumpet laminectomy, which is the group 3, I didn't understand surgically exactly how they're doing it, but what they're saying is that they're protecting the supraspinous ligament, interspinous ligament, and the paravertebral muscles. And what they're doing at the end is they're splitting the spinous process from the beginning and rebuilding it and putting it back into place. So they're somehow doing a laminectomy, removing the ligamentum, but reconstructing the lamina after. So here's some of the data from their study. Group 1 was the bilateral laminotomy. Group 2 was the traditional laminectomy. Group 3 was the trumpet. And you can see that at 12-month follow-up, the bilateral laminotomy group had better overall patient satisfaction, pain reduction, and improved performance. And anatomically, this can make sense considering theoretically you're preserving a lot of the structures, you're not stripping the muscle as much. Also, something else that I found in this paper was that following the learning curve, the risk of dural tears was reduced in the laminotomy group compared to the laminectomy group, which is interesting because the space is lower, but I think comes with the learning curve and understanding truly what you need to decompress rather than always doing everything. So they looked at the reoperation rate. Post-operatively, they looked at a CT and they found adequate decompression in all the patients. None of the patients required any reoperation, and the adjacent level stenosis requiring additional surgery occurred in one patient in group 2 and 2 patients in group 3. So not too substantial. This can do with just the natural disease process in itself. Here's some additional data. There are a couple of other papers that are out there that show, one shows that bilateral laminotomy produced major advantages, and the other one saying that bilateral decompression through a unilateral approach is effective without causing any instability and adequately decompressing the spine. So in this paper that we looked at here, they're showing that they recommend bilateral laminotomy. So there's a lot of different techniques that are out there. When you look at the biomechanical aspect of it, this study looks at 8 porcine models. They did an L4, L5 laminotomy versus a complete laminectomy, and they did hydraulic testing and flexion and extension. And what they found was that under extension, there was no difference, but under flexion, the intervertebral displacement of the laminectomy specimens was greater than those that had the bilateral laminotomy. So that they concluded in this small study, theoretically, is that the lumbar spine that has a intact posterior ligamentous complex is less likely to develop any sort of segmental instability at the level that they had that laminotomy. Here is another study, systematic review, looking at 2,400 patients, and they looked at open laminectomy procedures, comparing them to minimally invasive. And it's kind of a broad category. And if you look at the top right, you can see the surgical techniques that they used to describe whatever fell into the category of minimally invasive. But they stratified the patients, they looked at them, and they found that minimally invasive surgical procedures can help protect the patients from requiring any surgery from spondylolisthesis that may happen, which is a reasonable concern because causing iatrogenic spondylolisthesis may happen even if you're maintaining a significant amount of the facet joint just because of the degeneration you're causing. Laminectomy with fusion, I just included this in here because I think it's important to understand that it's not always decompression. If you're going to iatrogenically compromise the stability, whether it's deliberately from taking out more facet just to get an adequate decompression. And you also want to consider how much of the contribution of the patient's disability is from the back pain compared to their leg pain. So this brings into question the patient's history when they come into the office, physical examination, SPECT scans, how to counsel the patients on how much improvement they're going to get, et cetera. Here is a study that is a systematic review looking at the effect of laminectomy on spinal sagittal alignment. And actually some of these things I started to think about and consider after going to SRS and considering the overall alignment in small level laminectomy procedures. And it's doing a systematic review. It's tough because of the heterogeneity and the quality of evidence is low. You can see that the right side, the surgical techniques are quite varied. So to come to some generalizable conclusions is difficult with this. They say that decompression can have a small, statistically significant, but probably clinically insignificant effect on the lumbar lordosis. This is a study looking at sagittal spinal pelvic alignment after decompression surgery, 109 patients, and they looked at SVA, radiological parameters, clinical outcomes, health-related quality of life measures. And they found that in group B, which was the group that had sagittal alignment, there was a significant decrease in the postoperative SVA compared with the preoperative SVA. And this can do with many things, but I think the main reason that they had shown this is because there's a postural aspect to it instead of just structural, where they have a forward flex posture to decompress the canal. Here's a study looking at the impact, again, of sagittal spinal pelvic alignment. Retrospectively, they looked at 83 patients, sagittally aligned versus unaligned, and they looked at some of the disability health-related scores, and they found that patients who had a positive SVA had significantly negative effects on clinical outcomes and after a lumbar decompression surgery. Can this be because they're worsening the alignment? It's hard to say exactly because I think the data just doesn't go into those types of details there. Here is another one looking at the analysis of adjacent segment degeneration with laminectomy above a fused segment. I was wondering, because where I had trained prior, would they do a lot of maybe 3-4 level decompressions, complete laminectomies above a 1 or 2 level fusion without any consideration of any of the overall alignment. So this study looked retrospectively 171 patients, and they found that there was no significant increase in the adjacent segment disease with a decompressive laminectomy above a fused lumbar segment. Here's another one looking at the question that I was curious about is looking at a laminectomy in a lumbar scoliotic curve and the outcomes and the feasibility of doing a procedure such as this and how destabilizing it could be. So they retrospectively looked at 60 patients and they stratified them into stable versus post-laminectomy instability. And the instability was defined, as you can see, that second bullet point down under there by any of one of those 4 measures. And the laminectomy was extended to 1 level in 32 patients and 2 levels in 24 patients and 3 levels in 4 patients. And in their study, they found that about 20% of the patients underwent revision surgery. Here is a chart looking at the data of the patients, and the groups that were stable are on top and the iatrogenic instability patients were there. And the causes of revision surgery on the second from the right column, you can see there are a couple of different reasons, and progression of the kyphoscoliosis and the degeneration of the curve is relevant in a lot of the instability ones, and recurrent stenosis was the reason for revision surgery in the stable groups. There's another study there. Here's looking at unplanned second stage decompression of central canal stenosis. So when we consider neurogenic claudication, central canal stenosis, how much indirect decompression can we get? And here's a study looking at just this. There are several studies out there. Their study concluded that if there are osteophytes in the lateral recess or significant foraminal stenosis, then they recommended that indirect may be inadequate, which I think is kind of controversial because from what our understanding, foraminal stenosis is one of the better indications for doing indirect decompression surgery. And here's one looking at ALIFs, again, indirect decompression surgery, and they found that the spinal canal size improved by average 43%. So there are several studies looking at the spinal canal size, foraminal area, et cetera. I think about 30 to 40% is pretty common finding. And when we're considering the indications for neurogenic claudication, I just wanted to bring these 2 slides up to shed some light on it and maybe bring some discussion on outpatient surgery for an indication and treatment option for these. Different pros, different cons for doing these surgeries on an outpatient basis versus at a surgery center. I think there's taken into consideration an increase in the hospital reimbursement, decreased surgeon reimbursement, and surgeon ownership, which are all factors. But when we are figuring out as there's trend toward taking these surgeries to an outpatient center, we have to consider the indications for the patients as well as the surgical procedures that we can do for neurogenic claudication and lateral recess stenosis. And that's it.
Really nice summary overview, Shalin. So, what do you reflecting on the information that you got compiled here? How are you going to do things? Tell me how this affects your upcoming practice.
Yeah, so I think theoretically, I've thought about this more so now than ever, considering how I'm trying to indicate patients in my mind based off of what my prior training was, and thinking now at the theoretical and practical advantages of maintaining some of the stability. My ideal would be to obviously do the least amount in order to get an adequate decompression. And when I'm talking about decompressing the spinal canal, I think one of my goals here is to learn how to do a unilateral approach and a bilateral decompression, because to me, it makes sense maintaining as much of the facet capsule contralateral side, maintaining as much of the bony stability that you can in order to minimize any sort of adjacent or that level segment degeneration. So I think doing the least possible, and the laminotomies that you guys are performing and the unilateral approach, bilateral decompression, that's very appealing to me, because prior to that, everything was without any regard to the alignment, and we would be doing T12 to L1, just complete laminectomies in maybe even a relatively kyphotic type of spine, which now to think about it, I think that does make a difference on patient outcomes.
It's funny. That's how I trained too. It was just open lammy, but some of the studies that you quoted began to come out. So I think it's good that you're thinking about how to optimize outcome in the world of decompression, which is, I think a lot of times overlooked because we've got, all these other big reconstructive surgeries that people want to focus on.
Right.
But really the bread and butter of spine's doing these little surgeries, and chances are you're going to have a lot more impact in your life through those kind of surgeries on the number of people. So it's good to have a little focus on it. What you mentioned something about back pain. So tell me how, and this is going to be a little more granular. How are you going to utilize that factor, that issue of back pain in decision making?
So I believe that, and I had included this on my slide, is that I think there's an element of back pain that occurs with patients that have severe stenosis of their central canal. So, and I, this is not based off of anything specifically, but I think if a patient does have a severe central canal stenosis and an element of back pain, I don't think that I would necessarily chase down the etiology of discogenic back pain as being a part of it, and seeing how to, if minimizing what I can do to try to relieve it. But I think the main thing that I'm going to implement is the patient counseling part of it. They're saying that if you do have back pain, we don't do these surgeries for back pain. You may have some relief of the back pain, but it's not going to be 100%. What we're really treating is the leg pain or the radiculopathy or the neurogenic claudication symptoms that you're coming in with. I'm curious to see also as I go through these several weeks how to implement the SPECT scan, because I'm looking at the patients post-operatively, just clinically on post-op in the hospital, to see the amount of kind of the thought process that's going through the SPECT scans. And I'm curious to see if you guys have anything to add with that type of data as well.
I think it's a good question, but I would be a little bit cautious about utilizing SPECT for everybody that you want to do a decompression on, just to see if you should fuse it. I don't think we have that kind of data yet. Just reflecting on what you said about back pain, I think the tact on counseling's pretty good, but I might adjust it a little bit, because I don't think it's fair to tell people that their back pain won't improve. I see that language with people, that we don't do the surgery for back pain, or that back pain won't improve. Those are too strong. I think what you do is stick to the data. The data, I think probably some of the better data is out of the Canadian realm. They did pretty large scale population studies on LAMIs or decompressions, and they found that 70 to 75% of back pain, people's back pain improved substantially. So it may not be as responsive as radicular pain or leg pain or sciatica, but it isn't unresponsive. It's just not as reliable. So I think that you are wise to not only make clinical decisions based on that, but also counsel patients with that kind of language in mind. In other words, is it fair because somebody has back pain to fuse everybody that has back pain? I don't know that we should be doing that when 75% of the time people get substantial back pain relief.
Right.
Those are big health economic questions I don't have the answer to, but I tend to be a little bit cautious knowing that fact, unless somebody has instability or they happen to get a SPECT. But again, SPECTs are several $1,000s or a lot of radiation. I might be a little cautious about throwing specs at everybody that has this, relatively stable spine and stenosis, that your first inclination would be a decompression, but they have some back pain. You know what I mean? That may not be the sweet spot of that resource utilization.
Right. And how about flexion extension films to see if any instability is contributing to the back pain, or do you think that could just be another confounding factor too?
Well, I think that's important. If you have legitimate mechanical instability, well, then you have your answer, right? We know those people tend to do better with fusions, but we tend not to do a lot of flexion extension views because the sensitivity of a supine MRI against an upright lateral radiograph is actually a bit better. So, if you're sort of on the fence with that comparison, then I think you can get a flexion extension set and see if that shows something different. Sometimes it'll uncover an instability that wasn't obvious with the other comparison. But generally speaking, you can pick up most of it, and even better with just the supine versus upright imaging comparison.
Okay, got it.
But otherwise, excellent. Oh, and then one other comment with decompressions, and you talked about the unilateral, and the other faculty can weigh in. I think that you have to be a little bit selective about when you do that based on anatomy. The interpedicular distance and the depth of the wound plays some role of that. Now, tubes make that a non-issue, but tubes also can challenge some of your view as well, because they make it a little bit harder on occasion to see the ipsilateral side or to get the angle back, because the tube's going to run up against the spinous process a little bit more than just an open. But the depth of the wound, the angle, and the interpedicular distance can make it challenging. And then the other factor to keep in mind, and this is based on the studies, radicular pain in particular has tended to do a little bit better with bilateral laminotomies. And they'd never really, I think in the study, determined exactly why that is, but I'll give you my impression. And that is, when you do a unilateral, particularly, let's say in the lower lumbar spine, it's not all that easy to get the ipsilateral side or the lateral recesses well decompressed, particularly on the ipsilateral side because of your angle. And the lateral recesses are more critical in the lower lumbar spine. So, from a strategy perspective, I've tended to favor doing bilateral laminotomies at L4-5 and L5S1, occasionally L3-4, because those levels tend to give you more lateral recess cramping. And then at L1-2 and L2-3 and sometimes L3-4, where the interpedicular distance is narrower and the central stenosis is more of an issue than the radicular pain, the unilateral approach tends to work a bit better in my view, because you're really just trying to expand the central canal, and it's a little harder to protect the facets doing laminotomies unilaterally or bilaterally. And so if you just come in on one side, then you preserve the other one entirely. So that's sort of my thought process. Upper lumbar unilateral approach, because it's usually central stenosis. The caudal part of the lumbar spine tends to favor the bilateral approach because the lateral recess tends to be a more critical part of the equation.
Interesting. Makes sense.
Any other input? Hanny, Greg, Jamie?
Hey, Bob, I agree with you completely. I agree. Yeah, it's the same. I have the same feeling. The lower lumbar levels are better with bilateral. And again, one of the issues is we don't know what the primary stabilizer is, right? If you're trying to preserve stability, is it the interspinous ligament and the spinous process, and the fact the muscles now have a place to attach back to when you're done? Is it the preservation of a unilateral facet more posteriorly? You're still taking it, medially, and within the canal. If you're going to drill out the medial facet and take the lateral recess, you can do that well. That's hard to do across the canal. You have to take away a lot of the spinous process to get across there to get that secondary lateral recess on the contralateral side. It's really hard to get that well, especially if it's bony. If you got a bunch of bony stenosis on that contralateral lateral recess, it's really hard to take that superior articular process overgrowth off from on the contralateral side through a single approach. I think that's what I've found.
Yes, that was a comment I was going to make. If it's bony, then I'll typically go bilateral. If it's soft, I still think you can get it from unilateral pretty well. also that usually if patients have radicular symptoms, it's almost always unilateral. You can get bilateral. If it is, then I think Bob's comments make good sense. But usually there's a sided dominance that, even sways you to which side of the, spine you go on for your unilateral approach. Because that's the side you're going to want to try to get decompressed just a little bit better. But it's definitely more difficult to get the bony stenosis from the contralateral side, but the soft tissue works really well. Awesome. Any other comments? You guys hear me?
No other comments.
Cool. All right. Well, listen, guys, have a great Monday and beginning of your week. And we'll see many of you tomorrow. Otherwise, we'll get on the call again on Thursday. So have an awesome week.